So let's start the management part of snakebite. The first aid mantra for the snakebite cases is do it right. R stands for reassurance. Reassurance means you try to make the patient calm. Remaining calm is important as it helps slow down the spread of venom in the body. Panicking may increase the heart rate and the blood flow, causing the venom to circulate faster. Take deep breaths and try to relax as much as possible. Do not attempt to catch or kill the snake as it can put you at further risk of being bitten again. I stand for immobilization. When the snakebite occurs, it is crucial to keep the affected area immobilized or let the patient do not walk. This helps prevent the venom from spreading further into the body. Immobilization can be achieved by using splints or improvised material. Let's discuss something called Sutherland's technique. This is a kind of pressure band immobilization. In this technique, we are trying to immobilize the limb by applying a splint and apply the bandage over the affected area. We can use crepe bandage, even we can use cloths also. Or for the splint purpose, we can use a rolled newspaper if nothing is available. By reducing the mobility of the affected limb promptly and effectively, you can help minimize the potential harm caused by the snakebite, and the most important thing is you can buy crucial time until medical help arrive. But this Sutherland's technique is contraindicated in viper bite because viper bite lead to local necrosis and this may lead more complications. The rolling cloth or crepe bandage should not be applied too tighten. Okay, you need to check the tightness of the rolling cloth or the crepe bandage by putting your finger inside it, because remember, the goal is to keep the limb as still as possible to prevent venom from spreading through the lymphatic system. Now, GH stands for go to hospital and T stands for tell the complete history to the doctor with the appearance of the snake if you remember. When patient comes to the casualty with the history of snakebite, he will be presented with the symptoms like palpitation, chest heaviness, uneasiness, breathing difficulty, and on examination you will notice his pupil is also dilated. And these symptoms are mostly due to fear of death due to snakebite. So our first step in the snakebite will be reassurance to the patient. Irrespective of the bite, whether it is poisonous bite, non-poisonous bite, you have to reassure the patient. There will be three scenarios in the snakebite case. Okay, the first scenario is 70% of the snakebite are non-venomous. Patient will be bitten by a non-venomous snake. Okay, we reassure the patient and observe the patient. Now come to the 30% cases which are due to bite of venomous snake. In those 30%, 50% of the cases does not show any kind of symptoms because either the bite is dry bite. Dry bite means snake did bite the patient but his mood was good. He did not inject any kind of venom in the patient. See, what I am saying is snake like elapid family has a good control on their venom delivery system. Okay, so it is not necessary that every time they bite, they inject the venom. And the other reason may be impenetrable shoes or the angle at which snake did bite you. Now the case is of ophitoxemia, means envenomation. The snake bite and the venom enter in circulation. Okay. See, there is no role of tourniquet ligation. By the time you tourniquet, venom is already in the circulation. Okay. By applying the tourniquet, you may harm the patient by blocking the circulation. This may lead to the necrosis of the affected limb. See, as we know, in India, most of the snakebite cases are from the periphery and patient brought to the casualty with the tourniquet. In these cases, what we do is we need to apply BP cuff proximal to the tourniquet area and inflate it. After removing the tourniquet, we gradually decrease the pressure of the cuff because if we release the tourniquet suddenly, the sudden flow of venom may contribute to the rapid progression of symptoms to the diaphragmatic paralysis, or the release of histamine may lead to the hypotension, which is due to vasodilation. In the viper bite, patient will be presented with PPS, that is painful progressive swelling, with tenderness, bleeding and local necrosis. You will also find regional lymph node enlargement. As the time progresses, the patient will be having black colored urine, that is due to hemoglobinuria, and severe abdominal pain and flying pain due to submucosal bleed, retroperitoneal bleed. With the loss of blood and release of histamine, there will be fall in BP dramatically. Okay, here the patient is going into DIC, that is spontaneous bleed and shock. There will be acute kidney injury. Now, elapid ophitoxemia. This includes COBRA bite, that is a painful bite. Patient will understand that snake bite him. The second is KRAIT bite. KRAIT bite is a painless bite. It is a occult bite and it's mostly occur in night time. By the time patient understand, patient will be in paralysis. Now, these patients will be presented with first dropping of eyelid, that is ptosis, due to paralysis of levator palpebrae superioris. With the paralysis of extraocular muscle, this lead to double vision and there will be ophthalmoplegia. Second is paralysis of jaw and tongue, due to which you will notice a lot of secretion and frothing from the mouth. The patient may die due to aspiration. Third is dysphagia. Dysphagia is due to the paralysis of tongue. With the paralysis of vagus nerve, patient is unable to speak clearly. Okay, this is dysarthria. Fourth is paradoxical breathing. The paradoxical breathing is due to the diaphragmatic muscle paralysis. Now come to the very important point, that is a casualty based diagnostic workup. Okay, the 20 minutes whole blood clotting time or 20-minute WBCT. What we will do is, we take 2 ml blood in a dry glass test tube. We put it aside and don't even disturb this test tube for 20 minutes. After 20 minutes, normally what happens is the blood will clot. Even if you turn the test tube 90 degrees, the clot will retain itself. If the blood is not clotted, it means the bite is by hemotoxic snake. And this is a strong indication of starting ASV as soon as possible. See, after starting ASV, we will do WBCT in every 30 minutes and after 3 hours, we will do it 1 hourly. Now, the second is single breath count. This is very important test. See, ask the patient to count 1, 2, 3 or whatever he can speak in a single breath. What will happen is patient will be unable to count. If the test is positive, this will imply that the bite is neurotoxic or patient is in respiratory paralysis. The test will give you a good idea of a severity of neurotoxic bite. The third test is ask the patient to raise his neck while he is in supine position. The patient will be unable to raise his neck in case of neurotoxic snake bite due to paralysis. Okay? Now, after all things, let's talk about the management part. So, the management part will start with the first point is reassurance. Okay? And the second point is pain management. The pain management is by injection PCM. Not any kind of IM injection. It is just only IV injection, that is PCM injection. Say no to IM injection. The second point is use of BP cuff. This is a culture in India that patient will come with tourniquet ligation. Okay, so what we need to do is, we have already discussed that we will apply the BP cuff on the proximal to the tourniquet. Okay, and gradually decrease the pressure. Now, the third is the judicial use of ASV, anti-snake venom. See, you should not give ASV in each and every snakebite cases until or unless you know the sign and symptoms of envenomation. Okay, because the source of ASV is a horse serum. It is a non-human origin, so it is very highly reactive. Okay, so what happened is, when we give ASV, that will react in our body and it may give some allergic reaction or the patient can go in anaphylactic shock. In India, we use polyvalent ASV, and in a snakebite case, we actually use 10 to 20 vial of ASV, and rest depend on the symptoms. Okay, the dose of ASV for adult, child and pregnant female are same. And do remember that the ASV will only work against unbound venom in the body. See, our Indian anti-snake venom is highly effective against common cobra, not king cobra, soy-scaled viper, KRAIT and Russell's viper. As the Indian ASV's half-life is 90 hours, so most of time we don't need to repeat the ASV. Now, there is no use of skin testing of a potential reaction for ASV as per the research. Okay, if the patient develops an anaphylactic reaction to anti-snake venom, the effusion should be stopped temporarily and the reaction treated immediately with the IM epinephrine or IV antihistamine like diphenhydramine and a glucocorticoid like hydrocortisone. Once the reaction is controlled, if the severity of the envenomation warrants additional antivenom, then the dose should be restarted as soon as possible at the rate of 5 to 10 ml per hour. Now, the last is patient with clear objective evidence of neurotoxicity. For example, ptosis or inability to maintain upward gaze should receive the test dose of neostigmine. We first pre-treat with atropine 0.6 mg IV and then treat with neostigmine 0.02 mg per kg IV or IM. If the objective improvement is evident after 30 minutes, then we treat the patient with neostigmine 0.5 mg IV or IM or SC every 1 hourly as needed, and the atropine should be given 0.6 mg as IV continue infusion over 8 hours. Closely monitor airway and perform endotracheal intubation if needed. And some other treatments are hemodialysis, wound debridement and infusion of FFP.